Welcome to Airway Conversations. Dr. Mike DeLuke, board-certified orthodontist, and Nicole Goldfarb, speech-language pathologist and certified orofacial have joined in this Airway Conversation series to unravel the mysteries of airway health. Together, they'll dive deep into the connections between breathing, sleep, facial development, and overall wellness. Each episode will tackle the questions you've always had, and maybe some you didn't know to ask, about how airway issues impact children and adults alike. Through lively conversations, expert insights, and practical advice, Dr. DeLuke and Nicole will explore topics ranging from early intervention and orthodontics to tongue ties, breathing retraining, and so much more. So whether you're a parent, a healthcare provider, or just curious about the science behind optimal breathing and health, this podcast is your go-to resource. Let's start the conversation.
How are you, Dr. DeLuke?
So good, Nicole. So good to see you. This is so much fun to do this. I'm so glad we are getting to combine our respective fields and join forces to be able to share this message with our colleagues. Also, on top of that, laypersons and people who just want to know more about navigating in this space. So I'm really excited. This is our second of our series here, maybe third if you count the one we did as a joint episode, but of the official Airway Conversations, our second of the series. And I'm really looking forward to diving deeper into this content with you.
Same here. And I think we both have the similar type of curiosity when it comes to breathing health, sleep, wellness, and how that relates to orthodontic treatment, muscle function. So I think we have fun conversations ahead. And one thing I want to ask about from our last one, our Airway Conversations, is you and I had a funny conversation after that one that we recorded, because we were talking about sleep studies and we were talking about how the scoring criteria for children and adults might actually be the same. Like it's not supposed to be, but I had not realized. So I was telling you, I'm like, no, children, the scoring criteria is 2 missed breaths per every sleep cycle. And adults, it's not breathing for 10 seconds or more to score that as an event. And you were saying, well, actually, no, not all labs go by that. And so we talked with Dr. Simmons, sleep doctor and specialist, and he clarified. And I thought this was really interesting that he actually said that all sleep labs might be scoring sleep studies differently, and they don't need to follow the American Academy of Sleep Medicine rules and guidelines. And labs, cash pay sleep labs, can actually use whatever scoring criteria they want. And not all sleep labs are required to go by specific pediatric and adult guidelines. That's crazy to me. I did not realize that labs can just have free will to do whatever they want in terms of the scoring.
Yeah, and it depends on, as Dr. Simmons talked about when he was on my show not too long ago, it sometimes depends on insurance. It depends on the training of the particular tech. It depends on not only where they were trained, but when they were trained and by whom. So it is, I've had it described to me by an ENT, a pediatric ENT colleague, as the Wild West, the sleep lab industry. There are recommendations that the American Academy of Sleep Medicine puts out there, but that would be like, for me, the American Association of Orthodontists or the American Dental Association. They have certain recommendations, but those aren't rules, laws, guidelines that you have to follow. They're like best practices, right? We recommend this. But in the sleep lab industry, it's crazy how much anything goes, especially when you're talking about children. And one of the things I learned through our discussion and conversation, it actually helped me to learn more about it as well from you and from Dr. Simmons. And that is that the scoring criteria changes. Children aren't just children, as in, say, under the age of 18. It's different for infants and then under the age of 6 and then pre-adolescents and teenagers, because their bodies are changing so rapidly. And no one really knows, because there are a lack of normative data on pediatric sleep in general. So it's really a lot of guesswork. And I want to qualify that by saying it's not, and I don't want to put words in your mouth, but I don't think you're saying either that we say there's no value of a sleep study at all for a child. What we're saying is you just have to take those results with a grain of salt and look and say, this isn't the end all be all. Looking at this as an AHI and an apnea hypopnea index score. And for parents out there, that's the parameters that they judge sickness or health by in children. If they have an AHI of 1 or greater, then your thoughts that your child, okay, they have obstructive sleep apnea and they have a problem we have to deal with. But if it's less than that, 0, then they're fine. And because there's so much variability in how the sleep labs run these studies, can I tell you a quick story about what just happened to me at the residency with this exact thing?
Let's hear it.
So I'll give the short version here because it's quite a lengthy process that we've been going through with this little guy. But we detected that this patient, 6-year-old patient, has significant sleep disordered breathing, right? He's got all the signs and symptoms. He has dark circles under his eyes and he's open mouth breather, loud sleeper, snoring, narrow arches, high vaulted palate, lack of oral motor tone, tongue thrust, anterior open bite. I could go, he's like the poster child, right? Posterior crossbite. So we look at this, and with the residents now, I'm teaching them not just to look at fixing this little guy's teeth, but the etiology, the why. So we started going down this path of airway, and I started asking mom the questions from the Shervin questionnaire, and come to find out he's on meds for ADHD. He is very emotionally unstable in ways. He's struggling in school, even at his young age. He's struggling interacting with others. And mom tells me how he breathes at night, and he's suffocating all through the night. Mom's like, I hear him choking all night. He can't breathe. Now, no one had ever mentioned anything about airway to them prior to this. Interestingly, he had gone for an ENT eval of his adenoids, and I believe they didn't remove them. Don't quote me on that. They might have, but we took a cone beam and there's still significant adenoid tissue present. So I apologize. I can't remember whether he had a partial adenoidectomy or hadn't, but he had seen an ENT. And he's got insane congestion and obstruction of his nasal passageways, turbinate hypertrophy, all again, because we took the cone beam. I requested it on him and we were able to detect these issues. So I started talking to mom. Mom becomes essentially, teary-eyed and like, I'm so happy someone's going to try to help. I have been so worried that something's really wrong with him. And he has some other medical issues as well. And so I just thought this is how he was. Well, so we start going in with my phase 1 arch wire expansion and braces and wires, which we'll talk a little bit more about today. So we're doing that on him. Mom comes in, it's about 8 weeks into treatment. And mom says, I'm already noticing a change just from us doing what we were doing in the mouth with expanding with braces and wires. He's already sleeping better. He's not snoring as loudly. His behavior's starting to come around, and we're seeing it in the chair. He was really tough at first, and he's come a long way. But I had also referred them back to the ENT and to the allergist, because I said to mom, as we talk about often, but I want everyone to hear, it's not just about what the orthodontist can do. I'm there to normalize his intraoral anatomy, but I want others to work with us. And I actually am trying to get myofunctional therapy with the clinic on board, but that's something else we'll come to in a little bit. It's not easy at these universities to get them to incorporate things that they may not be aware of or believe in. So we'll talk a little bit about that too. But mom took him back to the ENT. Mom took him to the allergist. He's still going through the process of getting his allergy testing done. He had to be on prednisone for something else, so he couldn't do the testing. But go to the ENT, orders a sleep study. Just last week, they come in with a sleep study. Mom's got it in her hands. Mom's amazing. She's got this folder. She's on top of it. She now realizes we're going to help her little kiddo, and she is so appreciative. Mom says, it came back that he doesn't have sleep apnea.
Oh, no. I had a feeling you were going to say this. Okay.
So
now
the
what?
ENT won't do anything. And I told him, because I had prepped mom for this. I said, if the ENT orders a sleep study, I just want you to know all of the things that we've reviewed that are going on with him mean he has a breathing issue and a sleep issue, but it might not show up in a sleep study. And the resident's there for all of this. It's been an amazing teaching case for this resident. And so she comes back and she's like, you were right. It came back as he doesn't have obstructive sleep apnea, and they won't do anything with him. They said, he's fine. He'll probably outgrow it. So yeah, just keep in mind the speed that he's on to manage his ADHD symptoms, right? And let the poor little guy suffer. So I started asking mom a couple more questions about the test. And I said, well, one of the things is kids have faster respiratory rates and their threshold to negative pressure challenges is different. And it can be why in kids, a lot of times we won't see any apneas or hypopneas or 2 missed breaths unless they're in deep REM sleep. And mom said, well, how do we know if he got in a deep REM sleep? And I said, well, it should be on I said, I'm not the sleep study expert, but it should be on there based on their sleep cycles and whatnot. And they should know. She's like, well, they woke him up at 4 a.m. to end the test.
Oh my gosh. Okay.
And
So
I'm like,
that's when REM sleep is usually at its longest cycle.
Thank you.
Yeah.
And so I said to mom, wait, what? And she said, yeah, they woke him up at 4 a.m. and stopped the test. And the results say he's not obstructing. And so I said to mom, well, what did you say to the ENT? And she said, I explained to him everything you've been saying to me about that these other factors. And he said, they're dentists. What do they know about sleep medicine?
Oh man, jeez.
So my mom is like, she's like, so we're finding a new ENT because he's been dismissing her and her son for all this time. We actually are getting to the bottom of this and trying to figure this out. But it's such a good example of how if you trust those numbers and don't look at the signs and symptoms of your patient, you can miss this and ignore it. And the medical community doesn't understand it. And the dental community certainly doesn't understand it. And so we just say this kid's nothing we can do. And yet now we're already in there. And again, we're going to get him a new ENT. I've been making connections near the hospital with new ENTs and allergists, and we're going to get him to somebody who is good, and we'll hopefully be able to go help this little guy out. But that's a case in point example of the challenges we face with sleep studies.
With sleep studies. And there's so many lessons from that story. There's so much to take from that. First of all, I'm thinking that maybe that ENT is like, I can't do anything because they have to go by insurance guidelines. And if you don't have the diagnosis of apnea, well, then insurance might not cover adenoidectomy or whatever. One possibility. Another thing I gather from that is, thank goodness they saw you first and you explained and put the disclaimer out there. You let the mom know what the problem is. She was on board and trusted you. Because if she went to that ENT first, that child maybe would have gotten no help at all. Never would have maybe gone to the orthodontist or sought any help, and might be on a stimulant for the rest of his life, struggling and having issues, brain damage that ensue from that. So, I mean, it's so important for us as therapists to really educate our patients on what we see, the etiology. I find most patients, once they understand, they trust everything. When you explain it and you explain what's going on, it's like you said, kind of like that light of hope, that the tears of joy because somebody has an answer.
Yes.
And then you give them the information and the warning that, you know, this sleep study or whatever might not be accurate. And I can't believe that they woke the kid up at 4 o'clock. I've heard of this even for adults they'll do split night sleep studies where the first half, they don't use a CPAP or an oral appliance.
Okay.
And then the second half.
Oh, got it. Sure. Yeah. Yep.
Right. And they try the mandibular advancement device, or they put the CPAP on, and they are missing the severity of the diagnosis of sleep apnea because they are doing the therapeutic technique the second half of the night when it would have been worse. So we're not getting a true clear diagnosis, because we all know that REM sleep is at its longest stages. It lasts the longest towards the later parts of the morning, like 2, 3, 4, 5 a.m. Right. And that's when sleep apnea and sleep disorder breathing is going to be at its worst. So yeah, I think really the take home message too is, if a sleep study shows like apnea or severe apnea, okay, we're good. We get it. But if it doesn't rule out a diagnosis.
Oh, so well said. Yeah. So well said.
Mild, it doesn't mean you're fine. Go home, whatever, change your position. I mean, I've had friends I have a friend who he and his spouse have to sleep in a separate room because his snoring is so bad. He did a sleep study, and I believe it was actually a take-home sleep study, and it said mild, and it's just positional. And the guy said he's like, oh, I'm mild, I'm fine. And that was it. No further help. So it's just really interesting how there's so many different guidelines as to what labs are using, how they're scoring it, when they're waking the patient up. These are things we don't even ask about. So we really need to educate our families that we're working with.
Yeah. And the first night effect, which an article in Sleep Medicine Reviews in 2012 by Yoon, not Audrey Yoon, it was a different Yoon, who mentioned that. And they said that to get a real objective assessment of a child's issues from an airway perspective and to detect if they do have obstructive sleep apnea, you need 2 or 3 successive nights And essentially you can throw the first night out. So we all know insurance ain't paying for these kids to sleep there 2 or 3 nights, nor would it really be practical in their lives or their families' lives to go do this, right? So what's the answer? So we just keep doing this and going down this path, acting like this is okay. And the thing that gets me so frustrated with that, which is why I love how you said that, yes, if they come back that they're severe, you can pretty much rest assured that there's a problem here. Right? You probably almost certainly have an issue. But if it comes back they don't have an AHI of 1 or greater in the case of a child, it doesn't mean they're okay. And what else did that lab test for RERAs, respiratory effort related arousals? Did they what are their oxygen saturation, their CO2 stats? What is the bigger picture of this child? What is their body movement telling them, right? Mom literally came back and said he didn't score high enough. He didn't come back he was a 0. So the ENT said he's fine. And I'm like, oh my goodness. And this was exactly what Jerry Simmons said on my podcast. He said, if you have this happen, or if you have a child, what he said is, if you have a child who is snoring and you have a physician or a dentist tell you it's fine and you don't need to do anything about it, find another physician or dentist.
Exactly.
And I think that's the take-home message to any parents listening or any providers who are in a similar situation that you and I have both been in, where you have this happen and it's very frustrating. But another point that you made that is really good that I want to drive home is, this is why it's so important to do your diagnostics and to have time set aside in that first visit to communicate with the parent. Because as you indicated, if I hadn't prepped mom on this and explained to mom what was going on to gain mom's trust and help mom understand that I knew what I was talking about and we were trying to help her son. I mean, if mom never went to the dentist or the orthodontist in this case and just happened to go to the ENT, which is actually, like I said, she went to an ENT years ago. I'm guessing this is probably what happened. They did not do a sleep study to my knowledge, but she was told there's nothing that can be done for her little guy. And how do we break from that? I know getting the message out, like what we're doing now, is important, but it's such a systemic problem in both medicine and dentistry. How do we get people to see this? Because this is all evidenced in the literature. If you talk to brilliant people like Dr. Simmons, he can tell you any of this. So, I mean, I ran into a guy in the gym who turns out he's a pulmonologist and he does sleep studies. And I got talking to him about it. I'm like, oh, that's crazy. And he said the exact same things that Dr. Simmons says about this. So what do we do?
Yeah. It's like some people know. And I mean, if they can get to us first, we can help guide them and get another opinion, have them get a second, a third opinion. And we lead them to the providers that we know understand about airway and sleep and overall health versus just medicating our kids, because it almost seems like it's so common to just give kids medication. And sometimes we're blaming it on technology and the modern era, video games, so kids can't pay attention to school and things like that. But really, a lot of children and adults have airway issues, breathing problems that are impacting their sleep quality. And sometimes parents have to drive, or even when we're seeking help for our own selves, we have to drive far. I mean, people fly to see providers. You have to just make sure you're going to someone you trust, who has the education that's in line with what your concerns are. And like I had to drive 3 hours to take my kids to an orthodontist for a certain technique. Sometimes we have to do that to get the right treatment. Otherwise we're treating symptoms. So I know it's crazy, but I think, the sleep study aspect, it's important to have sleep studies, but it's also important to see other components and to have a really good diagnostic evaluation. And one of the things you mentioned about that case, that 6-year-old, is that you had the CBCT imaging. So you could see the adenoids were large. You could see things. How important
and
is it?
And I helped mom to see it, which was huge too, because mom said to me, sorry to interrupt you on that, but mom said, I told him I could see it for myself. There was nowhere for the air to go. So sorry to interrupt, but yes, helping the parents see it.
So perfect. I had an ENT once tell me that CBCT is too detailed and it's confusing because there's too much detail shown on a CBCT. So he likes a lateral set.
Excuse me?
Like, what? Yeah, that's what he said. So when they looked at, this was years ago, looking at my son's tonsils and adenoids. They were doing a lateral ceph, and I brought in the CBCT from the orthodontist. And he was like, nah, those tend to be murky and mess up the image, and it's too much detail for us.
Oh, goodness.
I was like,
I've never
what?
heard that one. Wow.
Now, that was years ago, but I don't know. I mean,
Oh.
so how important is it, do you think, for orthodontists and dentists to have a CBCT in their office?
So I get asked often, do you need to have 3D imaging CBCT? For parents out there who may not know what that is, or you can probably Google it quick and see, but it's basically a 3D image of the skull instead of the traditional 2D imaging, which would be like a lateral ceph or a Panorex, which is the kind of traditional orthodontic imaging that's been done for decades. So cone beam CBCT came out in the early 2000s, and initially the machines had very high radiation. And the reason I'm explaining this is because if you go to somebody and they say, well, we don't take cone beams or 3Ds because the radiation dosage is too high. Most companies now, I installed one of these machines in my practice in 2014. That was what's called a low dose CBCT. And it takes a very, very high quality image at a very low dose of radiation. In fact, a full 3D image of the skull with one of these low dose machines is about half the radiation of a single 2D Panorex. Just repeat that. A full 3D with one of these low dose machines is approximately half the amount of radiation of a 2D panoramic radiograph. So now you can ramp these up a lot, and you could deliver a ton of radiation with them, not the level of a head CT for someone who needs to go to get a medical CT, not of that level, but you can still get magnitudes that are double, triple, quadruple what you would do with a panoramic radiograph. But you don't need that for the initial diagnostics and screening in a child. You get some of your craniofacial cases or more detailed, where you need really detailed anatomy, then that's different. But for your standard child that comes in to see you, you can absolutely glean all the information you need out of this low dose image. So if a parent takes a child and they say it's a radiation issue, then that provider either isn't aware or hasn't invested in the technology that does it at a lower radiation. The other part that I hear a lot of objection to people in this is liability. They're afraid that if they take this image, they might have something on it that they don't know or they might miss.
Oh, I never thought about that. Okay.
It's a big thing in my profession. It's a big thing. I'll come to the third obstacle in a second, because a lot of people are like, why don't more orthodontists have these? But that's the second obstacle.
Responsible then if there's something on the image that you did not point out because you didn't know some pathology. Okay.
Yep. You're liable. So what some people do is they send all of them to be read by a oral maxillofacial radiologist. And there are different companies. You can submit them online. You upload them. It's not super expensive. And we basically did it at cost for patients when we did that. I probably had less than 10 my entire career of 10 years of taking these that I ever sent them out. But because I instead went and I learned from my ENT colleague on the cleft craniofacial team how to read them. So I just went and said, teach me what I need to know. We know all the anatomy. Any orthodontist has studied the craniofacial, the head and neck anatomy, like ad nauseum. It's been something drilled into us. So we know the anatomy. We're just not used to looking at it in 3 dimensions like that. We're used to looking at it in 2 dimensions. And when you look at it in a 3rd dimension, much like you can see a lot more, well, now you're responsible to read a lot more. Mm-hmm. So a lot of people do balk at that. But what I say to people is just send them out for a while and look at the radiology reports and look at the image. And after a little bit, you're going to understand it. And then when you're ever in doubt, you just send it out and let the parent know there's an added fee because I see something here I'm not confident in. So sadly, what happens, like what we're still doing at the residency, is we take 2D images on everybody still. And then if we see something we want to look more into, we go take the 3D, but now you're adding additional radiation. And I never understood that. So I'm working to try to get that change at the hospital, but it's part of a hospital system. It's so hard to make those changes.
Sure. With the university, it's so hard to make different changes.
Oh my gosh, it's brutal.
I feel like that would be so important for the residents and all practitioners to know how to read CBCT imaging, because those are the areas you're diagnosing and treating. Some of your work as an orthodontist might not be to the best of your ability without being able to visualize the adenoids or other parts of the airway. So I feel like that education and knowing how to read those is only going to help your treatment process.
Unless you don't want to see it. And I don't say that to be like snarky, but let's face it, sometimes you don't want to know what may have gone on or something, you can keep yourself a little blind to the whole airway thing, to where the roots are when you finish treatment. Because you put it in 3D, you're going to see if you tipped a root in a direction that it shouldn't be in much more detail. And I think they worry about the liability therein as well. And the third part of that, that's a deterrent to people taking them, because again, a lot of people ask, like, why isn't this standard? Is cost and integration. So they're expensive. And if you have multiple orthodontic practices, you have to integrate them across like 4 or 5 offices. And it takes a whole different level of training of your team. Your data storage is insane because they're big files. They don't all integrate with practice management software programs. So you have to buy separate software for every computer you want to view the image. So there's obstacles. So again, I want to make it clear that if an orthodontist doesn't invest in this, it's not that they're intentionally neglecting to, it's just, there's a lot of obstacles to doing this. And hopefully in time, as the costs come down and the integrations get better, and it'll start to parse some of that out. But as far as whether or not you can diagnose this or detect these issues or be aware of airway without 3D, I tell people there are a lot of things you can see without a 3D cone beam that will help you understand if your patient is suffering from sleep disordered breathing or sleep related breathing disorders. And much of those we've gone on in this prior episodes that you and I have talked about. But with the face, the mouth, there's a lot of things you can detect. That being said, what you just said before about wouldn't you want to see the adenoids, the nasal passageways, you just can't see that. When I lecture, I show cases where I'll show a 2D Seth and it looks totally fine. And then I'll show the 3D and the adenoids are like 80% obstructive. And so a lot of people say, well, I can see the adenoids on a Ceph. Well, you only say that until you actually look at it on look at it on a 3D after that, and then can really make that assessment. So you can be airway aware as a provider. You can understand this. And I've trained and coached many doctors in private practice to do a lot of what I do without having a cone beam. That being said, the ones that really take it to the next level and work with their medical colleagues in a much more efficient manner and really understand this tend to be the ones that have cone beam.
Yeah, that makes sense. And thank you for clarifying that too, because it's not just like a neglect type thing. If someone doesn't have it, it is really expensive and a lot of integration of software, you said. And I can see if someone has multiple practices, you can't afford to buy one for every office.
And then you're not systematized. So I've had people tell me, well, they try to put one in one office, but they rotate assistants through different offices and staff. And then even if they have a written protocol, in a busy day, they get flustered. They don't know how to use it in that office. So you'd almost have to implement them across all your practices at once. And that you're talking big bucks and big. So anyway, it's a challenge.
It's important if all providers are aware of signs and symptoms extraorally, looking at the face, facial features, history. And in the mouth, because you can see so much just by knowing what red flags are. And one other thing I just thought of, when my son did the lateral ceph at the ENT's office, the tech angled his head. You can see his chin is up and the ENT's like, oh, his airway's fine. Look how wide it is. In a neck hyperextended posture. And I think you would think an ENT would know that's not the position you put the child in, because that's going to be the best possible airway. Right. So it's also another
CPR position, I call it, right? The head tilt, chin lift.
Chin up. So it's going to take that soft tissue at the back of the throat, the pharynx, and widen everything. So you're not getting a true image when that person is in their normal posture, how they're breathing, or the child or adult may be posturing that way to breathe. And you have to look at those details on the scan. And that's why it's important for ENTs, I think, to understand about body posture and breathing and those components versus just looking at structures.
Did he look in your son's mouth as far as from a transverse deficiency perspective or crowding or, I mean, it's nice of the AO, and we talked about that before, but it's nice of us to punt to the physicians and say they should be the ones to really quarterback this, but they're not looking at those areas. So I don't know why we don't step up and take ownership of it.
Yeah. And I heard you mentioned once how we were told airway orthodontists need to calm down about all this.
Yeah.
Have you heard that?
Yeah. So one of the things that frustrates me with where orthodontists stand from a professional standpoint, this isn't talking about individual practitioners, but from the American Association of Orthodontists and our sort of leadership organizations, is they continue to focus on where we started this conversation, and that is a diagnosis of OSA with a sleep study with polysomnography. And it's almost like if they don't have that diagnosis, they are literally like, kid is fine, no problems, nothing to see here. And that's why I get frustrated with the AAO white paper, because it mentions OSA 276 times, and sleep disordered breathing or related breathing disorders, I think it's 15. And over half of those are in references and appendices. It's talking about children who are diagnosed from the sleep study with OSA. And when that comment you just referenced was made, was at a meeting, the winter meeting of the American Association of Orthodontists. It was a joint meeting with the American Academy of Pediatric Dentistry. And some people that I coach and teach and they follow my content were there, and they messaged me and said, we're in this meeting right now, and somebody said that you're going to have to get a grip, or it was like they disapproved of Airway Ortho. And yeah, like you said, they need to calm down about it.
I wasn't sure if I should bring that up now or detail.
Yeah,
I was
yeah,
like,
no,
I remember you said that, and like,
yeah.
how frustrating.
Right. And these people are picked to speak at these meetings for a reason. They know who we are. It's a reason they won't let me speak at these meetings. It's the reason why I apply and keep getting rejected. Because I'm not saying it as like but I've been on plenty of big stages in front of big audiences and spoken. I have the credentials there with what I do, and I teach and on faculty and everything. So those criteria, I'm not saying that at all in a pat on the back to me, but those are a lot of the things that they look for when they're looking for a speaker. But my content, they tell me when I want to speak about sleep-related breathing disorders or sleep disordered breathing, I've been told multiple times by them, and I share this openly because it's not a secret. I'm not ashamed of it. I just think it's unfortunate, is that my content is neither interesting nor relevant. And that's a quote from them twice when I've applied to speak on sleep disordered breathing in children and how it differs from OSA and how it takes a team approach to try to deal with these things. And also been told that they are afraid that I'm going to promote indiscriminate expansion, which you and I can talk a little bit more about today if you want. And that is orthodontic code word for expansion in the absence of a crossbite, of a posterior crossbite. So they don't like that I expand when there's not a crossbite, and they don't like that I'm talking the way I talk about this. I don't quite know why yet, and maybe I never will. I have some thoughts, but I certainly don't know why that's the case. But they had a lecture, Nicole, on serial extractions at this meeting. They literally had someone come up and talk about the benefits of serial extractions. And the time that they did relegate to Airway on the last day, they put a few hours in the morning on the last day of the meeting, and it was titled for orthodontists and the diagnosis and treatment of obstructive sleep apnea. So again, it's all about diagnosing and treating obstructive sleep apnea to them. And I just don't know. I mean, that's not, I've called them out on shows like this, on my show. I've called them out to say, like, you need to do better. I know the president. I've reached out to him personally. Like, I had the previous president on my show, but they won't change. And so maybe the parents listening and the lay people, give a call to the AAO. Maybe if everybody, we have to approach this from a grassroots level. Everybody reach out to the American Association of Orthodontists and tell them to get with it, get a grip, and start to look more into the fact that a child does not need a diagnosis of OSA to have an airway problem, that your orthodontist should be the quarterback of these issues and needs to learn in their training how to work with or myofunctional therapists or facial myologists or speech language pathologists in some capacity, whatever. I know every community doesn't have every one of those particular providers, but most communities have a speech and language pathologist. You can at least start by teaching residents how to communicate. Most of them have a school on speech language pathology right near where the dental school and the ortho residency are. Start to work in the inroads to develop us understanding a little bit more about this stuff. And then working with ENTs and allergists, et cetera. It has to come from the AAO, unfortunately, or else these programs, because of the accreditation process, they're not going to just go rogue on their own. And some of them will and are, and I give them a ton of credit, but a lot of them just walk the company line and follow in lockstep. And so, yeah, call the AAO. If people hear this, call the AAO. Anybody, call them and just tell them enough is enough. They need to get with it.
Yeah, because we know ASI and having apnea is end stage disease, but
Thank you.
simply mouth breathing, even if it's only open mouth breathing when you're sleeping, is a problem. That is the first step in the problem, or that is one step of the problem. And if we're just saying, oh, it's AHI and you have apnea. And if you don't have apnea, then you're fine. Then they're missing a huge percentage of people that could be helped who are developing into a more severe problem.
Or you might have apnea of 9 seconds.
Right.
Or not miss 2 successive breaths. Or go to a sleep lab where they wake you up at 4 a.m. before you're in deep REM sleep, right? These are the types of things that literally make my head want to explode, because how can such smart people, like a group of orthodontists that are highly, highly educated, be so ignorant to these facts?
It's true. And this whole crossbite thing. So I definitely want to talk about that, because I've had situations where I've had patients. There was a 13-year-old girl that moved here from another country. Her palate was so narrow and she was snoring. I mean, she had major sleep disordered breathing. And she came in for a myofunctional evaluation with my colleague at the office. And my colleague, this girl was referred actually by the orthodontist, and my colleague said she needs expansion. There's no space for her tongue. And the orthodontist, he was more traditional, and he's like, no, we don't expand when there's no crossbite, meaning, and you could explain that better. So if somebody's not sure what that is, if a parent's listening, can you explain, Dr. DeLuke, what a crossbite is?
Yeah. So in simple terms, a crossbite is when the upper teeth are inside of the lower teeth. So upper teeth all the way around should always be further out than the lowers. So if at any point there's a lower tooth that goes further out than an upper, or an upper that goes further back than a lower, that's technically a crossbite. It could be of a single tooth. It could be of multiple teeth. It could be of the entire front of the teeth. It could be an entire side of the teeth. I've had patients where it's the entire front and both sides, right? So there's all different levels of severity of crossbite.
And there's always the palate, and tell me if I'm wrong, but from my education, when there's a crossbite where the upper teeth are inside the lower teeth, that means the palate is narrow, whether it's on both sides or just one side. And from a myofunctional perspective, we find that the tongue is not supporting the palatal width in order to help the palate grow nice and wide. And sometimes it's just on one side, so unilateral crossbite. When we paint the tongue in our evaluation, some of us use like a sodium fluorescein or something where we can see where the patient swallows. We'll find that the side where the upper arch is inside the lower arch, the tongue has dropped and is low posture during swallowing and breath.
Interesting. I didn't know that. Interesting.
On that side, yeah. So we find consistent with that. Also, the way the person chews also can impact that. So this 13-year-old who she was a sleep disorder breathing case. She had malocclusion. She had narrow palate. The orthodontist did not want to do expansion because there was no dental crossbite. Now we can see a narrow palate, but the teeth are lined up with each other because of dental compensation. So can you talk about what that is?
Yeah. So the example I like to give for this, it's such a great question. And I can, at the end, I'll kind of comment on my confusion as to why orthodontists don't all see it this way, because from a pure scientific and bone biology, tooth anatomy, functional perspective, you can't deny what I'm about to say. It's not my opinion. This is the facts of our occlusion. So if you have one patient that walks in, okay, patient A, let's call it, that patient has a very narrow upper jaw. And as a result of that, their narrow jaw is in crossbite on both sides with the lower in the back. So the lower is wider on both sides, called a bilateral posterior crossbite. Upper jaw narrow, lower jaw normal width. Upper jaw sits inside the lower jaw. You would be hard pressed to find an orthodontist who wouldn't go in and expand on that patient, even as early as 6, 7 years of age, right? Maybe even a little younger. Some orthodontists go in on those even at 5, 6. Even orthodontists aren't a big fan of any relationship to airway. Don't even think that the orthodontist has any role in airway. Still would see a place to go in and expand that patient. Because remember, we're wired to think about malocclusion. That is a definable malocclusion. Crossbite. Take patient B. Same exact maxilla, same exact upper jaw, identical, right? Patient B doesn't have a posterior crossbite at all. Their lower jaw, the bone, is the same width as patient A, okay? So both their jaws, upper and lower, are the same width. But patient B, their lower teeth have angled in and are caved in so that they don't sit further out than the upper teeth. They fit in a quote unquote, air quotes, normal occlusion, right? Meaning when you look at it, that patient does not have a crossbite. We don't look, and truthfully, this is where cone beam again is very helpful, because in cone beam, you can take a coronal slice and you can look at the widths of bone, and the maxilla, the upper jaw, should be a good solid 3 millimeters wider than the lower jaw. So you would see that in a cone beam, but in 2D imaging, unless you take a PA-CEF, it's called, but almost no one does that routinely. So you wouldn't see it. So orthodontist sits down quickly with a patient, looks in their mouth, like the patient you were just explaining, looks and says, they don't have a crossbite. There's no transverse, no width issue here. There's no transverse
We
problem.
literally will say, like, kind of bite down. They take their photos. Teeth are touching correctly. They don't pay attention to the angulation of the teeth.
Yep.
And they, oh, okay, no crossbite, no dental crossbite. Okay.
Yep. And Jim McNamara, Dr. McNamara, who's one of the most respected names in our profession, he had a paper in the AJODO in 2000 where he said that a maxillary transverse deficiency is the most pervasive skeletal problem in the craniofacial region, but that it's often not detected by orthodontists because it's often not associated with posterior crossbite. And he said if it's camouflaged by the dentition, which is patient B, right, and both arches are constricted, it's going to typically be missed by the orthodontist, and they're only going to probably focus on the resulting crowding, because when everything is squished in, what happens? The teeth get crowded. So they look at patient B as having no problem of the transverse at all, even though in patient A, they had the same width maxilla. They're like, got to expand that. That's a narrow upper jaw.
So basically, they're just looking at the teeth and their alignment, and they're not, are they measuring palatal width or looking at the arch looks high, the tongue doesn't fit?
No, they're defining it by the occlusion. So if that patient does not have a posterior crossbite, they're like, why am I going to treat a problem that's not there?
Oh my gosh. Yeah.
Even though, again, like I said, McNamara, this was 25 years ago. He put this paper out where he talked about titled, I think it was like maxillary transverse deficiency. I think was the title of it. I mean, it's not a mystery in that papers where he talked about the 36 to 39 millimeter width across the molars. And so it's known that this is a thing. But if you were to go to the majority of orthodontic residency directors in this country and say, do you have your residents expand in the absence of a posterior crossbite? I'm willing to bet you 3/4 of them would tell you no, probably higher. But so I don't understand that truthfully.
So they're just looking at the teeth, not the bone.
Just looking at the teeth.
Alignment of the teeth, not the jawbones.
And that's why, correct. And that's why they end up extracting in patient B. So patient A, who has a less severe malocclusion, right? Remember, because patient A's lower was fine. Their upper was narrow. And when it's narrow like that, patient A was going to have crowding in the front to canine incisors and canines because they're narrow. Anytime you squish it in, it's the same. It's the converse of why when you expand, you have space. If it's squished in and narrow, you're going to have crowding. So patient A would probably end up being treated non-extraction because they're like, oh, I've got to expand the upper jaw because there's a crossbite. So they'll expand the upper jaw. That patient's going to have better airway benefits. That patient's going to have less risk of removal of teeth. Patient B, they're most likely going to remove teeth because they're like, well, I can't expand the patient because there's not a crossbite. Why would I create this issue? And then they have the argument of that extractions don't cause airway problems. And my point is, no, you didn't cause the airway problem in patient B that might be there by those narrow arches, right? No, Grant, point conceded. You did not cause it by pulling those 4 teeth out. That patient came with it. What you did is you neglected to do anything about it. And you focused only on the teeth and treated the teeth only. In patient A, you somehow decided that you needed to normalize bone anatomy. And here's the other thing. You would never see an orthodontist, I shouldn't say never, but it would be very out of bounds for an orthodontist to say in patient A that they were going to cave the lower arch in to fit that upper arch, right? That would almost be unheard of. I'm sure there's some that might do that, but yeah, again, that would be such an outlier. It wouldn't even be something you wouldn't ever go try to defend that stance. Yeah, I'm going to okay, we're talking about children. Sometimes in adults, people do compensate that to avoid surgery and MARPE. And again, that's a different conversation. But in a child, you'd be very hard pressed to find a practitioner to say, I'm just going to like totally constrict the heck out of that lower arch and pull some teeth out so I can just cram that lower arch into that narrow maxilla. But in patient B, that's what the patient's anatomy has already done for you. And you're just letting it stay.
That's a mic drop. I'm going to call that a Mike DeLuke drop. Like you exactly said it. The patient came with the airway problem, but you didn't do anything to help it.
Yep.
And potentially made it worse if you're
Sure.
extracting.
Yeah.
I mean, wow. So we would call that a skeletal crossbite, right? Is that
Correct.
a term? Okay. So is that
just to define that, the only time you have really a dental crossbite is like bones are normal. You can have a dental crossbite and a skeletal crossbite. It gets a little bit confusing with that, but let's just talk that the bones are normal, like normal skeletal width. You could still have a tooth or two or three that are tipped in the wrong direction. That would make them be where the upper is inside the lower.
Okay.
You can also have what's called a buccal crossbite, which just gets kind of confusing, but just to be for the sake of accuracy, where the upper, instead of locking and alternating with the lower, is completely outside the lower. So the upper is like sitting, you can't chew that way, but the upper is like a full tooth outside the lower. So when I said before, crossbites when the upper is completely inside the lower, technically it's called a buccal crossbite, is when the back tooth, the upper sits like a full tooth outside the lower. Again, it has nothing to do with what we're talking about, but I just want somebody to hear what I'm saying and didn't think I'm being inaccurate in my speaking. But yeah, you could just have a tooth that is on the upper and is behind the lower or inside the lower, and that would just be a true dental crossbite.
Okay, it's really funny you're saying that because I've been looking up buccal crossbite, and is that the same thing as a scissor bite or
Scissor bite or Brody bite? People
Brody
call it a Brody bite.
Mm-hmm. Okay, Dr. Tracy Nguyen just said that because there's a Facebook conversation about this where someone's adult patient, the orthodontist said if they get SARPI, they're going to end up with a crossbite, and the patient didn't understand, and the myofunctional therapist didn't understand, and so I was responding out of my scope, but I think they're referring to a buccal crossbite if they don't upright the lower teeth. Okay,
you got it. 100% dead on. Okay. Yep, great job.
That's what happened to me when I had my MSC. I couldn't chew on one side; it was maybe expanding more. My lower arch was more tipped lingually, and so I had a buccal crossbite, but then they uprighted my lower teeth or decompensated them, and then they met again. So it's really
so you were like patient B, whereas you were narrow on both, and then they expanded your upper. And I'm so glad you mentioned this because I neglected to say this. So when we're talking about why the orthodontist doesn't want to expand on patient B, okay, which is the patient who doesn't have a crossbite and is narrow in both arches, they are worried that if you expand the upper, it's exactly what you just said. I hear it all the time. Well, Mike, if I expand the upper, I can only go a few millimeters, and then I'm going to be in Brody bite or a buccal crossbite or a scissor bite where your upper is completely outside your lower. And for the life of me, Nicole, I don't know why we have this belief, but we believe that you can't expand a lower arch dentally. I'm going to say that again. The orthodontic profession as a whole, more than not, I would be willing to say, and most educational institutions and most people in organizations like the ABO and the AAO, of which I'm a member and board certified, but they would believe and say that you can't dentally expand a lower arch to upright the teeth. And what they say, they conflate it by saying, well, you can't expand a mandible. Well, correct. The mandibular symphysis is fused around birth. You could do distraction osteogenesis where you cut it and then expand it. But we're talking about these patients, patient B and patient A. Remember, they both have the same width of both of their jaws, upper and lower, right? The same width. It's just that patient B, the teeth have caved in to sit in with that narrow upper jaw. The body is compensated. So we would never, and this is again what I say to people, you would never take patient A and cave their teeth in to look like patient B. Why wouldn't you take patient B and upright their teeth to look like patient A and then expand their upper jaw, which is what you were talking about that was done with you? I literally don't understand why we make that argument.
Yeah, and there's so many good points there. I did an interview with Dr. Brian Huckle, and he talked all about this. We're afraid to say you can't expand the lower, so we soften it with the term uprighting or decompensating. Right. So meaning you're just tipping the teeth upward so they're vertical in the bone. Okay, so this is interesting because once I started learning about this and looking at angles of teeth, I I don't know if all myofunctional therapists look at this, but we should be. When we're looking intraorally, looking at the occlusion, look at the angle of the teeth. Are they tipped? Are the lower teeth tipped inwards? Are the
Mhm.
upper teeth tipped outwards? Because that helps us in our diagnostic process as well. Because a lot of patients have had some orthodontic treatment to line up the teeth, but the jaw bones have not been corrected, or
Yep.
people will get Invisalign to straighten out their teeth. But you can see that teeth are like to basically line up the teeth so they're not crowded, but you can see that the teeth aren't angled correctly or
Yep.
vertically in the bone. That I don't know when I started like looking at that and thinking about that, but that really changed how I was evaluating patients as well. Someone might have a beautiful smile, teeth look great, but when you have them open and you look how teeth are tipped, you can tell that something is camouflaged. And the orthodontist of that 13-year-old girl who didn't want to expand, and I was just speaking to him from a tongue perspective. Her
Mhm.
tongue can't fit on the roof of her mouth. It's so narrow. He said, well, we wouldn't expand. She doesn't have a dental crossbite.
Mm.
And I said, have you heard of a skeletal crossbite? I don't know if that was like rude of me to say. I wasn't being rude. I just wasn't sure if maybe I wasn't saying it correctly, but he was
Mhm.
like, no. And he was an older man. So
Mhm.
the parents fortunately went and got other opinions who did say to expand, and they did expansion. But
Yep.
if I were to ask an orthodontist, or do orthodontists know that word, skeletal crossbite, or would
Oh,
they?
sure. Yeah.
Okay,
Yeah,
good. Okay.
sure.
Oh,
There's
great.
no doubt about it. He knows that word. I don't know the man, obviously, who you're speaking about, but you wouldn't get through our schooling because
Okay.
even a unilateral posterior crossbite, so not patient A that we were talking about had on both sides, but one side, that is almost always a skeletal etiology, meaning it's almost always the result of a narrow upper jaw. It is rare that you will have, it happens, where you would have all the teeth on one side just caved in. It happens, but it's almost always, even when there's a dental component, right? So even when the teeth on that crossbite side are caved in, there's still almost always an underlying skeletal component of that upper jaw being narrow.
I just had like a light bulb went off when you just said this, because now it's really clear to me that these orthodontists, they might even agree or admit the palate's narrow,
Mhm.
but the teeth are lined up. That's all that matters.
Yes.
So it's not that they're not even seeing the palate's narrow. They're just looking from the perspective of the teeth.
Right.
Because in my mind, I was thinking, well, maybe they don't even think the palate's narrow, but it doesn't even matter. They can think, yeah, the roof of the mouth's narrow or the arches are narrow, but the teeth are lined up, and that's all that matters.
Correct. And so on the 13-year-old patient you're referencing, I can pretty much guarantee you if her lower arch wasn't as caved in, so she either had a unilateral or bilateral crossbite, I can pretty much guarantee you that same orthodontist would have expanded her upper jaw.
That's so interesting.
I can basically guarantee it because he wouldn't leave a patient with a posterior crossbite because then the teeth wouldn't fit together. And sadly, as orthodontists, we focus on fitting teeth together over everything else. And I'm obsessed. Many orthodontists are OCD, so I'm not unique in that way. But we are like, I obsess over getting good finishes on my cases. I was very particular on that. So I'm not saying I'm an outlier in that. We all like that, but what we'll do is we will do that oftentimes. And I did this, I'm guilty of this early in my career before I went on my journey to understand this differently. This is how I approach cases, just like that gentleman, because that's how I was trained. And it was a journey I went on to start to look deeper into this, to say, there's more going on here. If I try to get these bones in the right spot and get these teeth in the right spot, I have to help this patient's transverse deficiency. And that's what McNamara was talking about in that article in 2000, where he said, this is happening all the time. We're just not looking at it because we're hyper focused on the way the teeth fit.
Yes, a tooth-minded focus. That's
Mhm.
just it made things so clear to me, because I think I thought in some ways they just don't agree. Oh, the palate's not narrow. They're not even looking at that aspect of
No.
it. Like, just look at the teeth, not beyond the teeth.
Yep.
Okay, one quick thing, and then we're going to end. But I learned from Dr. Kevin Boyd that whenever there's a class 2 malocclusion, so that upper jaw is forward,
Yeah.
there's always a narrow palate. And
Essentially, that's McNamara talks about that same thing in that article in 2000. Yes.
okay, so
Yep.
that's interesting. So as a child, I had a headgear because I
Mhm.
had a class 2 malocclusion.
Yes.
Okay, so I wore that thing religiously. I was a good kid.
Compliant patient.
Sort of. I was sort of a good kid, but at least for that, I had to wear it. Otherwise, I get in trouble. And but the palate was never addressed. So basically just held the upper jaw back for the lower jaw to catch up. So my teeth looked great, but I didn't think I had a narrow palate until as an adult, realizing, oh, my tongue is really scalloped. I have all these indentation marks. I have airway issues, blah, blah, blah. So I went to see Dr. Bill Hang, and he said, my teeth, they looked perfect. He said, your orthodontist, if he saw you, he would pat himself on the back, being so proud of how he lined up your teeth and look at that smile. But too bad he didn't pay attention to the body connected to the teeth. And so as an adult, I learned, oh, my palate's narrow. I needed to get expansion. Oh, that could have been addressed as a child and not headgear. And if the orthodontist realized that occlusion isn't just lining up teeth, but that malocclusion is actually deficient jaws in multiple directions, it would have taken, things on a different route. I probably wouldn't even be here making this interview because I wouldn't even think about airway so much. I might have breathed better and not had problems. But anyways, so it's just a lot of interesting things when we're looking at, we talked about sleep studies, looking at angulation of teeth and camouflage and how malocclusion versus looking at jaws and the whole patient's breathing and body. And I think it's just really interesting conversations with you. So thank you. And I like my new saying, drop the mic, DeLuke.
Well,
I'm
humbled by that.
Mike going drop.
Yeah. And your knowledge on this, Nicole, I don't want that to go unsaid. Just, it's so above and beyond. When speaking with you about this, you ask such phenomenal in-depth questions, thinking questions that show your depth of understanding of this more than a lot of dental practitioners spend the time to think about this. So I give you a ton of credit on that. And we can talk next time. In the next one, we can get more into the class 2 if you want. And how much of that is an upper jaw problem? Should you ever pull the upper jaw back? We can get into some of those conversations and why there's a width problem when there's an AP problem, because that does get confusing for people. And then I want to hear from you on some of the strategies you're finding that are most successful that we can work to integrate into our schooling, because we're not learning about orofacial myology, myofunctional therapy, speech language pathology in any capacity in the majority of our orthodontic residencies. And I've taken it on as a little bit of a new mission because I was challenged that there's not much evidence basis in that. You saw my one email I had, and I really appreciate you providing me some of that documentation, because it needs to be, this is a team approach. And you understanding this and asking these questions and getting this information out there is so valuable, because this reaches your community, my community, and the laypersons that we both reach out to. And these are the conversations. That's why we're doing this. When you and I talked about doing this a few months back, we're like, let's just kind of riff on this whole thing and just put it out there and let people hear what you and I would talk about if we were just talking at a meeting.
Yeah. And we could go on for 2 hours, but we won't. But we could keep going. And I want to tell you, I was thinking maybe we're going to talk about how orthodontists, some might think that myofunctional therapy isn't evidence-based. And I literally, if you're listening, you won't see this, but I have probably 14 pages of notes I wrote up.
I love it.
So in our next episode,
next one, let's do it.
I will school you on evidence for myofunctional therapy, and people can be armed to know what to say if somebody says it's not evidence-based. So stay tuned for our next one for that too, right?
Well, let's kick the next one off with that, if you would, because I would love to have you go on about that. That's big. And I want to learn more about it too, because I don't have the best answer to that question. I believe in it wholeheartedly, and I've seen it work, and I know that it is a tremendous asset to what we all are trying to do in this joint venture we're on. I just don't have the toolkit and the knowledge base to be able to really explain the science behind it and the neuroscience behind it to be able to make that argument. So I would love to have more of an education on that.
Yeah. And you don't want to be caught off guard promoting myofunctional therapy or saying, oh, this is great. And then deer in the headlights when someone's like, well, what's the evidence? And you're like, I don't know what to say. So we'll talk a lot about that in the next episode. Thank you so much. This was so much fun. I appreciate it.
That is like the fastest hour when we do this. It's crazy how quickly it goes by. I hope everyone else when they're listening feels it goes as quickly as
I know.
As I do.
You and I are having fun. That's all that really matters. But no, really, hopefully we're helping people answering their questions, because I am sure there are a lot of people who have similar questions that you and I have and similar discussions or want to learn about these things. So yeah, thank you so much. And I'll look forward to the next episode.
All right. Thank you, Nicole. Good to see you.
Talk to you soon.
All right. Bye.